Hi, this is Amelia again. So I'm a psychiatric nurse practitioner, and in this talk, I will speak about major depression. This is a very common condition, actually, and it affects anywhere between 20 to 30% of all American adults at some point in their lifetime. Um, there's a difference between, a depressed mood and a low mood for a period of time versus major clinical depression. So, to meet the criteria for major clinical depression, the episode must have lasted for at least 2 weeks, and often it's several weeks to several months, and for some people, years even without intervention. However, depression is self-limiting typically. It does tend to go away on its own even without treatment. However, it may be much, much less pleasant to go through it, and certainly can be quite distressing. So the most common treatments used in psychiatry are antidepressant medications, as well as atypical antipsychotics, which are often used in combination with your antidepressants, just because their way of working is very different and it works on a different neurotransmitter than your classical antidepressants like Lexapro, Prozac, Paxil, Effexor, Cymbalta. So atypicals tend to work on dopamine more often than not, which the previous antidepressants that I just mentioned don't decrease and in fact don't increase and in fact can decrease dopamine levels in your brain. So it's very important to really fine-tune the dosing. So often what many clinicians do with clinical depression is they'll keep increasing the dose if it's not working. And the higher you go on doses with these medications, the more flat and apathetic you can get. So at that point, it's not the depression, it's more of the side effect of the medication. So that's why you really have to be in tune with your symptoms before and during and after treatment, so that you are able to kind of identify whether you really are depressed or you're having these secondary side effects of this apathy and this feeling flat and just kind of nothing really bothers me, right? So I hear that a lot from people who begin treatment is, I'm so lazy, I feel like nothing bothers me, I don't want to do anything. But they're no longer feeling sad and hopeless or desperate, they're just more almost overly relaxed and indifferent to what's happening. And so that's how we know the med is actually working, and it's probably working a little bit too well. So we may want to actually drop it a little bit so that the person can have a bit more of that motivation and drive. And then again, major depression is very different from major depression in somebody who's got bipolar disorder, right? Also may be a little different from, and it coexists often with other conditions. So schizophrenia, ADHD, obviously bipolar disorder, learning disabilities, many other conditions contribute to depression. In fact, also heart disease and diabetes have been linked to higher levels of depression as well as autoimmune conditions, and obviously trauma. So people with PTSD often experience major depression as well. So this is just a little bit of information on depression. There are different presentations, and that is something that I will be discussing with you guys via our forums or our live sessions for Q&A sessions and things like that. Okay, thank you.